My name is Upashana Chandra, and I'm a fourth-year medical student at the Medical College of Georgia. Today, I'll be presenting a case of reversible Adalimumab-Associated Pancytopenia. To begin with, adalimumab is an anti-TNF-alpha biological agent, and it's effective in the management of inflammatory diseases such as rheumatoid arthritis. A rare side effect of this medication includes bone marrow suppression that leads to cytopenias, although this has been reported on only a very few instances. This patient that I'll be presenting is a 54-year-old Caucasian female with a past medical history of Crohn's disease and rheumatoid arthritis, in addition to several other chronic conditions, and she was admitted for severe headaches and intractable nausea and vomiting. At the time of admission, she had been on adalimumab therapy for her Crohn's and rheumatoid arthritis for about 8 months, with her last injection 2 weeks prior to admission. She had a known history of borderline low platelet counts, typically around 100,000. However, her labs were notable for pancytopenia. So she had low hemoglobin of 10.6, a low white count of 1.6, low platelets at 46, and an ANC or absolute neutrophil count of 0.2. However, she was pretty asymptomatic from a hematologic standpoint with no bleeding or infection. She underwent diagnostic testing to work up her pancytopenia, including a peripheral blood smear, which was only notable for anesopoikilocytosis, or variability in her red blood cell shape and size. And she also underwent infectious workup and metabolic and endocrine labs to rule out a secondary cause of her pancytopenia, including iron studies, folate and B12, thyroid function testing, and HIV testing, and hepatitis testing, and all of these were all unremarkable. We also tested her for paroxysmal nocturnal hemoglobinuria, which is a rarer cause of pancytopenia. This was normal as well. And so this brought us to doing a bone marrow biopsy as well as obtaining aspirate, which is shown on the images here. Her bone marrow aspirate smears are the top part of my images, and overall this was pretty unsuggestive of a hematologic malignancy. If you look at the pictures, the only real abnormality here are just an increased number of red blood cell precursors and some noticeable dyserythropoiesis. And then her bone marrow biopsy is at the bottom here. You can see that it's slightly hypercellular, but it's adequate and overall unremarkable for a hematologic malignancy such as leukemia. Again, here you can only really see abnormalities in the red cells and platelet lines, but we also had some evidence of mild reticulin fibrosis, which prompted us to do some testing for myelodysplastic syndrome, including a karyotype and FISH, and this was totally within normal limits as well. So overall, we just decided to hold her adalimumab for 3 weeks, and we followed up with her in our outpatient clinic. And a CBC obtained at that time demonstrated a resolution of pancytopenia with results that you can see down here in the bottom left corner of my poster. So overall, this case illustrates pancytopenia in a patient with Crohn's disease and rheumatoid arthritis that resolved in response to discontinuation of her adalimumab therapy, and this is one of few reported cases of this occurring. Why is this important? So if undetected, pancytopenia can actually leave a patient vulnerable to potentially life-threatening bleeding and infection. Autoimmune diseases such as rheumatoid arthritis or lupus, among many other etiologies, are known to cause dysfunction in bone marrow and mild marrow atypia. In the setting of cytopenias, this marrow atypia may actually result in an inappropriate diagnosis of myelodysplastic syndrome, when really their pancytopenia may have just been a byproduct of their medication for their autoimmune disease. So, in conclusion, this case highlights the potential need for monitoring cell counts in patients who are on adalimumab therapy in order to avoid missing the rare but very serious complication of pancytopenia. Furthermore, pathologists and clinicians alike should be aware of the potential of cytopenias occurring due to this medication in order to avoid misdiagnosing myelodysplastic syndrome among other entities to ensure more accurate and higher quality of patient care. My references that I used are at the bottom right hand of my poster, and I thank you very much for your attention and time.